My name is Dr. Stephen Moore. I'm one of the founders of MD Solution. We're one of the leading distributors of Pharmanex. I've been working on this project for quite some time right now, and it's been very exciting to see really how some new technologies are really making a big impact on the way that many physicians are treating their patients. If you guys have any questions for me or need to reach me, my contact information is there at the bottom. We also have Dr. Paul Karpecki with us, and he's one of the leading experts in the world when it comes to eye care. He's an associate professor at Kentucky College of Optometry. He speaks at probably 20, 30 different conferences a year as a keynote speaker. He's also the chief medical editor of the Review of Optometry, which is the largest circulating journal in optometry. He works over at the Kentucky Institute and Gaddy's Eye Center. And he's actually a retinal expert as well. Completed his preceptorship at the Associates of Kentucky. We'll have a little bit later on Dr. Trevor Crabtree discussing a little bit about some of the things that he's done in his practice. Trevor's been practicing for 30 years in optometry. He's been a great leader to help advance the profession. And he's also been using our technology for several years now and has a lot of experience. He's actually the optometrist that helped Dr. Karpecki get up and running with this new technology in his practice, and is a great asset to our team. And I know that you'll enjoy getting to know him as well. So Trevor's contact information is at the bottom there. We'll also share this with you towards the end of the webinar. So just a couple intro slides here. When I do this talk a lot to different types of physicians in optometry and other medical professionals, I always ask these three questions. Are you satisfied with prevention in healthcare? Are you satisfied with reimbursements, and are you satisfied with, the lifestyle of being in practice? And very few hands go up. So we have a lot of problems in healthcare, and what we want to do here is solve some of those major issues to help shift healthcare more towards prevention. Optometry plays a huge role in this. Help physicians increase revenue as well as improve lifestyle. One of the new standards in eye care is the BioPhotonic Scanner, which we'll talk a little bit about tonight, but it's the world's first non-invasive way of measuring carotenoid status, and obviously that plays a big role in AMD and many other ocular diseases and overall health in the patient. And so on tonight's webinar, we're going to talk about AMD intervention and prevention, which is going to be presented by Dr. Karpecki. We'll talk a little bit about the role of carotenoid supplementation, how this new technology is a new standard for measuring carotenoids. And we'll talk a little bit about the brand Pharmanex and really what sets this company apart. This was a company that, as a chiropractor, I was really impressed with the research and development behind their products. We'll hear a little bit from Dr. Crabtree, and then we'll talk a little bit about how you guys can enhance and add value to the practice. And then what I also encourage you to do is at the end of this webinar is we'll have a short survey here. If you could just fill that out, give us some feedback, and that way, if anyone is, those of you that are interested in learning more about the technology or getting started with this, we'll have somebody reach out to you. So I want to turn the remainder of the slides over to Dr. Paul Karpecki. Thanks, Paul, for joining us. It was great spending some time with you down at Key West at a recent conference, and really enjoying getting to know you. You've been a fantastic presenter, and I'm excited to hear what you have to say tonight.
Thanks very much, Stephen. That was a great introduction. I don't know if I could do better than you did. I want to, first of all, thank all of you for being on the call. I know it's Thursday evening. There's a lot of things you could be doing. It's a busy time of year. It says a lot about you in terms of your dedication to your patients and your practice to be here, and I thank you for that. I apologize. I'm going to be a little more casual. I got really three reasons. One, I literally just got off a plane a couple hours ago. Number two, I had shoulder surgery about 5 weeks ago now, and by the time I get a nice shirt on and a tie, it could take me an hour and I'll be late. So that's number two. And then of course it's an evening, so you're going to catch me a little more casual. But I really think this is an exciting area, and so I'm really glad you're part of this because of the opportunity here in terms of managing these patients. There's really 5 areas to thrive, as you just saw. There's dry eye plays a key role if you look at the next few years of optometry. Diabetes, just over 30 million people, as with dry eye. Macular degeneration should jump from about 10 to 20 million over the next 15 to 20 years. Glaucoma grows, doubling in size, and so does cataracts. And the fact is, all 5 of these are affected by carotenoids. So this really plays a role in everything we do. If you look at the next slide on AMD, you can definitely, this is where we're going to focus today. Next, Steve. And next part is really looking at what our role is in optometry. And yes, There are times that we will pick up on drusen, as you see here in OCT, but I will tell you that this is a little late in the disease. Every disease you pick up early does a lot better when you can manage it to some capacity. We never had that opportunity with AMD in the past. We kind of waited until a patient presented, had decreased vision. We might have put them on an AREDS2 supplement if they were intermediate stage disease. If they were wet AMD, we now have anti-VEGF, but that's not a really good formula for managing these patients. The goal is not to wait until we're making a diagnosis here, but actually to take on a preventative approach and make a difference for these patients a lot earlier in their life. So even technology does play a role. So I don't want to get away from not using OCT. It's essential. I couldn't run my practice without that. I also work in a retina practice after having completed a preceptorship over the course of a little over a year. So it is important to be able to utilize, red-free technology to enhance images, to be able to identify the disease early. But I'll tell you that even with these advantages, and you go through the next slide, you'll see the red-free imaging really enhances what you're seeing. Actually, a few hemes here, probably some diabetes, some drusen and other changes taking place, and even new technologies like OnFOS that could help us to see geographic atrophy. And we do have to realize that there are classifications to AMD, and I think most of us on the call do understand that. The NIH actually shows, the next one after this one, Stephen, shows the different categories of AMD. And I will actually say that I think what we need to get good at is identifying stage 1, possibly even earlier where the risk factor is there, but at least at stage 1. The problem at stage 1 is you look at this image, it's really hard to see anything. It looks like a perfectly healthy macula, optic nerve, posterior pole looks fantastic. I have difficulty being able to say that this stage isn't pre, but it is. In fact, if you were to magnify this and look at some other ways of looking at it that we don't have capabilities of, you would probably see small drusen. Small drusen don't show up even on OCT, but there wouldn't be any pigment abnormalities. And yet that is early AMD. That's stage 1 AMD. Early is actually stage 2. So to correct myself, it's approximately 10 small drusen or less than 15, kind of in that range. It's our intermediate size. They're not any significant large ones. Again, you'd look at this and say it's very difficult to see, even if you magnified it. I would love for us to pick up more early AMD as well. The next slide shows you where we should be treating patients with an AREDS2 formulation. That's the intermediate or stage 3. There's a lot of doctors that know this, but I'm surprised by a lot of colleagues who don't realize that not every stage of AMD was studied when it came to the AREDS2 formulation. Really, the patients that were enrolled in the clinical trials for AREDS2 were these 3 categories. Intermediate stage, where you had at least 1 drusen that was over 125 microns. That would be about the size of a vessel leaving the optic nerve. So you could take a look at the drusen and reference it to one of the vessels of the optic nerve and have a pretty good idea if it's bigger or less than 125 microns. Advanced AMD, where you had geographic atrophy in one eye. Unfortunately, you've lost that eye, so to speak, in terms of vision. And the other eye is still functioning and still within the realm, or even more advanced where we get into wet, which would be, of course, our monitoring these patients and trying to treat them with anti-VEGF by sending them to a retina specialist. But again, these are important classifications because I want to make an emphasis that when I was going to school, and this was in the mid-90s, we really didn't have a lot of options. You either had the bad AMD or the good AMD. Not that either one was really good. I guess bad or worse. Bad being dry, at least you had time. You slowly lose vision, we'd monitor, and wet being the worst form. There really wasn't a lot we could do. Today, we can do a lot. Next slide. So current management of AMD is really, as we talked about, when you get to wet forms or exudative, you're looking at anti-VEGF. They gain over 2 years some vision, but the more of the injections and monthly or treat and extend options really eventually do dry the macula to some extent. Functional loss can be avoided today through timely intervention and early intervention. 70% of the time, which is really fascinating, wet AMD results in functional vision loss worse than 70 vision, so essentially blindness in one eye. And yet, when we make that diagnosis, we actually save the vision in the other eye 92% of the time. So every time I see this, I wonder, why didn't we do this the first time around? Why didn't we try to prevent the first diagnosis of AMD by anticipating it early, by looking for it, by making a difference in those patients, preventing them? And if you were to ask any one of your patients who has advanced exudative AMD in one eye and is holding on to vision in the other, they would all say the same thing. So we need to start looking at the earlier indications, night vision problems, patterns as far as what they're noticing when they go into a dark theater, not being able to adapt. Difficulty determining, the right vision is impaired because of AMD and other is also difficult for us. And we've got to get really to where we're looking for risk factors. Are they a smoker? What's their nutrition like? What's their heredity like? And sometimes it is like I just described. The patient goes into a dark room, dark auditorium, a theater, and they truly can't adapt for 8-10 minutes. That's a great indicator of early AMD. And in fact, that's what dark adaptometry is. And as we look at this technology here, I think this is one that is worth considering as well, because it's a great identifier of early AMD. And as I talked about, the earlier you pick up the disease, the better. If you look at the anatomy of the retina itself, and what you're seeing there are the karyocapillaris, and above that Brooks membrane, and then you get into the photoreceptors. What happens in very early disease, even stage 1 or prior AMD, you get drusen that essentially covers that, but you can't see it. You wouldn't see it on OCT. It's not large drusen. In fact, it's called basal linear deposits and basal laminar deposits. They are cholesterol, so they're made of the same thing, but they're not visible. And yet they are affecting vision. If you had something covering that transmission, just like a vitamin A deficiency where you can't get transmission in the photoreceptors, you're going to have early signs of dark adaptation, nighttime vision problems. So we do have some early adaptometry effects that can occur even before we start to see overt signs in the eye. Next, you get into the effect of AMD causing localized deficiency and breakdown, like we talked about with the vitamin A deficiency. That's also what essentially happens. It's typically described as having night vision problems. The next slide will show you, though, that there are ways now to finally be looking at this. And one way is DAPDX, which is a dark adaptometer. The patient puts their chin in there. Within 6 minutes, you'll know the answer. Really highly sensitive, highly specific, over 90% sensitivity, 90% specificity. And I will tell you, if you have one of these already, then what you need is to add the hand scanner, because they do different things and they're very compatible. It's almost an automatic to have the two together. I have both in my office. I've taken on AMD as a major component of our clinic, and I feel like it is really important to pick up on the disease early and be able to do something for these patients, because they're waiting till it's way too late to come in, and we're missing so many that turn to wet that would have had early signs but never had enough for us to pick up on other testing. The next slide, you're going to see how easy it is to do this. You put your chin in there. Within about 6 minutes, you would have a normal reading, meaning you adapt in that time. The next slide, you'll see a patient who didn't adapt in the normal time frame, and you can see it takes quite a bit longer for that patient to be able to get. The flashlight's interesting because in the machine, it doesn't flash directly into the macula. It doesn't bleach it because that gives you an artificial answer. It actually bleaches external to it, so it's really working just on the rods. Show the next slide here, Stephen. You'll see it coming in. And it gives us a chance now to really look at how do we manage these patients. And so I think the reason I put this slide in, and the last one, as I talked about, I think is an important test because it'll help you with early diagnosis, but it's not a test for monitoring the patients. Even though you can monitor, don't get wrong with that, there's ways to kind of look at it. I want to be able to know that what I'm using for my treatment is making a difference. And that's where, the hand scanner comes in and that technology around Raman spectrometry. But I also want to emphasize that we as doctors are no longer what I described back when I was in school in the 1990s, when we either had the person who had the bad AMD or the worse AMD. We really have a proactive opportunity. ARES2 formulations are utilized when you have intermediate stage or stage 3 AMD. Prior to that, you're looking at the benefits of carotenoids to prevent patients from getting to that level. And I think that becomes very important as you utilize these technologies. Next slide. So as this comes in, what I just finished saying is how critical it is in every part of eye care, how we look at evaluation. And this could be glaucoma, for example, where you evaluate, you look at the optic nerve, you look at the many tests that we have, and then we decide to put them on a therapeutic. Sometimes we do an SLT, but we decide to put a therapeutic. And then we look to see what happens. Are we getting a change? Are we getting progression? We do the same thing with an infection. We make our diagnosis, we treat them, and then we monitor to see what happens. When we're doing spectacles or contact lenses, we get a measurement ahead of time. We do our refraction. And then we look to see what we provided and did it give them the results. We reevaluate. Yet when we look at all of these nutritional supplements as we've talked about, and now that we have choices based on what diagnosis we make, there's no way to know if it's working. I mean, we know from studies, ARES2, that in that category, the intermediate stage AMD and advanced, patients had some progression compared to the placebo, progression, prevention, so to speak. But we never really knew if it was working or how well it was working or what the change was. And that's where we're talking today about the scanning technology, Pharmanex and the Photonic Scanner. But here's what I was talking about earlier. A lot of doctors, and I included a number of years ago, didn't realize this, that the NEI study, the AREDS2 study, really looked at a very specific group of patients who had AMD. And those were, as we referred to earlier, the patients that were at, stage 3 or intermediate stage, where they had at least one drusen that was as large or larger than a vessel leaving the optic nerve. And that's the formulation where an AREDS2 formulation comes in. And Pharmanex has an AREDS2 formulation. Bausch & Lomb did a lot of the research on this, the AREDS formulations. But I want to emphasize that that's where the category fits and where it's been proven, where it does what it needs to be. And the NEI showed that. And yet we need to be picking up on this disease decades beforehand and doing preventative things. We don't go to a dentist, and not doing anything preventive and show up with all kinds of cavities. It's a miserable situation. The goal is to prevent that from happening. The next slide will show you a little bit of that as we glance at the studies that showed specifically that. NEI studies showed that the best patients were those in that intermediate stage and above. Prior to that, we were better to just supplement carotenoids and help them from that standpoint, and it may help with macular pigment. So I want to emphasize what I showed you earlier. The no AMD, the early AMD, these are very difficult to even pick up. Your stage 1 and 2 are carotenoid supplement therapies and whole body approaches to their management. Stage 3, which is your intermediate, your geographic atrophy in one eye, are where your AREDS2 formulations come in, which is the next slide. In this category, you also have to be monitoring for that third stage, which is your advanced or your exudative, your choroidal neovascularization, where you can get obviously the wet and the bleed form. So you're monitoring these categories for it. So let's go to the next and get into this a little bit more. There are tests that have looked at macular densitometry. The problem with these, and so I want to be complete in this presentation, is that they're all subjective. And a lot of the research now shows you need to have an objective measurement. And I'm not honestly sure that it makes the most sense to be looking at the macula with blue lights and other imaging that goes in there. I think you're really better served by being able to look in other areas and then being able to correlate it. And that's what we're going to see with the photonic scanner, is that the data there is quick, takes about 30 seconds, portable. We bring this from room to room. I have this in my office. We actually keep it in the pre-testing area. So we have a patient that's coming in. Actually, we test anybody who smokes, who's a smoker. We test anybody we should test everybody, but we test everybody who is over age 50 or 60, depending on the risk factors. We test patients who talk about nighttime vision problems, and we test patients with a history of macular degeneration. And we also test patients who say they have not only nighttime vision problems, but difficulty when they put a bright light on adjusting or adapting to it. And then we will do this in the pre-testing lane. It's very quick, it's portable, cost-effective. And what's really fascinating is how poor our nutrition is in the U.S. and the levels of what you see in these patients, which gives you an opportunity to help the patient perhaps prevent AMD, but at least make their body healthy, help in many ways long-term. 99% response rate. This is very easy to do. You're not flashing on, bright light to look at the macula and getting pigment counts and anything like that. This is just done right on the hand. We'll show you how that happens. And then if that's positive, we know that we have some tests now to monitor. We do dark adaptometries I talked about. I look at the macula. I run an OCT. This is truly an AMD focus. And we've had great success with it. Patients have been extremely grateful for it. And I want to emphasize that the technology was not, the photonic scanner was not invented by the company that makes the nutritional products, Pharmanex. And that's important because, you want to think that they're creating something to then be able to sell it. This was actually independently made. It put in, incredible amount of research, 90 research study papers published, let alone the amount of research that went into it. And then it was Pharmanex that licensed this in Utah. And they actually were doing what the other macular pigment scanners did. They looked at, Gellerman looking at the macula and being able to look at pigment and measure the amount that's there. They found that, probably not the best way to do it. There are actually more accurate, objective ways of doing it, such as the photonic scanner. And quite frankly, as I said earlier, you probably don't want to be putting bright or blue light frequencies directly into the macula to begin with. So I think we just now finally have a better way of doing things. And that's Raman spectroscopy. And what this does is essentially you do still shoot in blue light, but rather than to the macula, where we know that high visible energy light could be damaging potentially, we put it on the skin, on the hand. And what that allows then is the rebound reflection off the carotenoids which, as you would imagine, as you put in blue light, the carotenoids reflect back. You get a green, actually, light source back. And that can be measured and can be plotted out to tell you exactly the level of carotenoids within the body. And I'm going to show you a little later how this truly correlates to macular carotenoids. Incredible correlation. And that's why I think this is the way to be looking at carotenoids and the level of patients are from a nutritional standpoint and the impact of your desired treatment. So if you look back to 1922, that's when Raman spectroscopy was first kind of developed, and actually won a Nobel Prize for it because of the level of what went into it and understanding it. And then they developed, as you can see there, this device, and you see the reiterations over time of the photonic scanner, and this is, as you can tell, over many years, almost coming up on a decade, or a century, I should say, from when it was first invented and first discovered as far as spectroscopy to then the device. And you can see that being developed as an in-office 1999 there, and then 2002. And you see as it continues to advance to where it is today. And what's really interesting is it actually won an award as one of the business innovations or big innovation champions. And what's interesting about that award is that's not just healthcare. And in fact, health technology rarely wins this award, and yet it did with this technology that we have access to. Next slide. So here's kind of how it works. The patient simply places their hand, the palm, and it's easy to do. They'll show you very well where to place it. The device measures it in about 30 seconds, and you get a reading. And as I said, 99% of the time, you're going to get an accurate reading on these patients and be able to tell what level they're at in terms of their current carotenoid health. And then I'll show you how it correlates to the macula in a moment. So what's really great, and I used this one study which came out of Yale that wrote specifically at resonance Raman spectroscopy evaluation of skin carotenoids, and found that it was a great biomarker for the carotenoid status in human studies. And of course, this one was pivotal, but there's actually 90 such studies that exist, 90, that look at this to date. And so it is a very well studied, very well found, very scientific technology that I think is really making a difference in our office. And obviously, there are a lot of centers that are involved in this, including SUNY. I know that Jerry Sherman utilizes this a lot in his clinic, and others that are here, Yale, Stanford, Texas Tech, and there's many more that are in there. It's utilized in the Olympics. We talked about it winning the Nobel Prize. So the Discovery Channel has talked about it. Actually, Dr. Oz had it in one of his shows, ironically. So the consumer part is actually heard about this a lot and adopted to it. And now it's the medical community that is realizing this can play a role. And then finally now we're realizing the optometric community might be the ideal scenario because we manage 88% of all comprehensive eye exams. We're the ones that are going to pick up macular degeneration and early disease. In fact, what's interesting is when Dr. Oz put this on a show, amazingly 94% of the audience failed. Now, if you've ever watched their show, it might not surprise you, but it is interesting that the numbers are that poor out there. Now, Dr. Oz obviously practices what he preached. He had a score of 75,000. I've got my score up to about 55,000, so I feel pretty good about that because before I started taking these supplements, I was probably, I know what it was because Trevor was the first one to measure me. I wasn't bad. I think it was like 37,000, which is actually considered pretty good from the averages, but a long ways from where you want to get to. And obviously, you want to get to levels that prevent disease progression because carotenoids are one of our most powerful antioxidants. So you can affect the entire body. But as we know, the issue of macular degeneration is essentially a breakdown in the macula caused by free radicals, and antioxidants fight that. So low levels are associated with a lot more than that, including cancer, heart disease, Alzheimer's, and high levels protect us from so many of these diseases and so many that we look at as optometrists. So this is really great data because this is an incredible number of patients, 7.5 million roughly, that's put into big data databases that have had the scanner. The number's now, I think, 20 or 30 million, some huge number that looks at it. But I love the fact that as you look at where the readings are and where you can get to in terms of what you're utilizing, it correlates amazingly well. In fact, I know we all kind of do this when we're looking at research, and I know there was quite a few faculty members on the call here as well. And I've always looked, every time I see a study that looks at contact lens complications or, dry eye or other issues, I always want to look at the percentage of smokers and how they fared. For example, there's more microbial keratitis in patients who smoke. So I think that's probably a legitimate study because smokers just have more bad things. So when I look at this and I look at smoking, you can see that it's around 20,000 and really low on the scale of carotenoids. Obesity runs at about 21, 22 in there, 25. Not eating fruits or vegetables had a lower count. So it's very correlated to the things we know that prevent, or that work as antioxidants, so to speak. If you had 6+ fruits and vegetables, you can see where I get to. If you're using things like a Life Pack and Life Lock, which I take, those really, in my family as well, make a difference as you start moving up. And then these patients who not only just took the supplements, but also ate healthy, a lot of fruits and vegetables, start getting incredibly good, successful numbers as we move up. And so it's nice to see when something is truly correlated to what's there. These are the 4 known risk factors for AMD: lack of actually vegetables, fruits that are high in carotenoids. Smoking is a risk factor. Obesity is a risk factor, and UV exposure. And so what's really interesting about looking at that now from this perspective, which is from photonic scanners or Raman intensity counts of spectroscopy, you'll actually see that correlates. The patients who reported eating 1 or less fruits per day tended to have numbers around 22,000, like I mentioned. As they increased the amount, it went up 24, 28, 31. So very good correlation in this huge database of telling us that we need to have our patients eating healthier, because the carotenoid counts within the body are very well measured by looking at the skin and in the macula are correlated. Likewise, you look at smoking, which causes free radicals that cause incredible damage. Oxidative stress is a known risk factor for macular degeneration. Non-smokers had a number averaging about 20,000. And as you look at smoking, depending on the number of packs per day, it correlated. And what's really frightening is the patients with 5 per day. Notice those are actually probably cigarettes at that level. You're looking at about 11,500. What an incredibly low level of carotenoid within their body. And we know that without having these antioxidants, the free radicals are able to run rampant. If we look at other categories like body mass index, and again, the green now in this case is the lower number. This was a database about 250,000 page subjects where they looked at their BMI in this research and found a very good correlation in terms of these numbers. The ones who, obviously the patients with the lowest BMI were up around 30,000 on their carotid index scores. And so really highly correlated. And I love that because it should be almost like a dose response based on the risk factor, what happens in terms of our body and the carotenoids that are there. And then finally, we could look at UV damage, because there are also studies showing that more UV damage, the lower the carotenoid counts. And actually, you might even look at some of the nutritional supplements, the vitamins, essentially as your sunscreen for macular degeneration. It's the way to protect the patient. And the earlier you apply sunscreen, the earlier you prevent UV damage. In fact, they say we really need to be doing it at a very early age in our children, the less likely to have problems 20, 30, 40 years later. And the same thing applies in terms of macular degeneration and carotenoids. The sooner we can treat patients getting their body health, the sooner we can educate them about these risk factors, the better we are. But in our world, we want to correlate it to the macula. We want to be able to say, okay, we're looking at the skin now. What does that tell us? Well, we've got some great papers. Here's an ARVO publication that looked at carotenoids. And really one of the most respected AMD researchers that I know of is Paul Bernstein. I've talked to him a number of times when I was researching this area and get great insights from him. And in their poster, they were actually able to show that the hand scanner is better than the subjective macular pigment measuring as far as existing macular pigment scores. I mean, they go and look at the pigment, the amount that's present, and then they would compare it to a macular pigment count, MPOD, in this case, the macroscope, and quantify, and the densitometer, so all three. And then they compared it to skin carotenoids, and they found, obviously, the photonic scanner had the highest, or scanner had the highest correlation to estimating macular pigment amongst them all. So it makes sense because the others are subjective, and that makes it difficult. But I'll tell you what really tipped me over to becoming a real believer, or to being able to do this webinar, was a gentleman called John Nolan. Dr. Nolan is, in my opinion, one of the foremost experts in the world in carotenoids. I just saw him last week in Las Vegas. In carotenoids, that's it. That is what he's done. And he's the leader of it. He developed MacuHealth. He's one of the people that played a key role in understanding it, and really is extremely scientific in the sense that he publishes whatever comes out. He wants to just better our understanding. And as I mentioned, his life is dedicated to one thing. He tells me that. I'm dedicated to carotenoids. I'm married to carotenoids. That's all I'm studying. I hope to be the most knowledgeable based on our research than anybody in the world, and I'd say he's achieved it. Well, he decided he wanted to also objectively look at the photonic scanner and see if he could correlate it to macular pigment and effects. And so I look at John Nolan's work continuously. In fact, I have him send me his papers when they come in, because I just feel like there's certain researchers you just want to look at. So when this came out, I was thrilled to see what way it went either way. And his assertion, as you can see from this, is again, very similar to what you saw in the Arbor study by Paul Bernstein, a highest correlation to macular pigment, best we can do, and correlated extremely well to effects of than looking at the macula and trying to subjectively come up to where we're at. Let an objective test in 30 minutes give us the answers. The next slide is really important. And this isn't something that we have done, well, it's not something anywhere in medicine has really, in my opinion, done well. Chiropractor's done a little bit better. Dentistry has done well in this area, perhaps, and that's preventative medicine. Diseases are always easier to treat if you catch them early, and are even easier if you prevent them. And we know that whether it's cancer, heart disease, macular degeneration, dry eye, doesn't matter. And we don't typically intervene. In fact, most of the research studies show that we tend to intervene very late in the disease when they finally are showing signs within the macula. And by the time you're seeing drusen in the macula on OCT, or even worse, being able to visualize it, you are very advanced into the disease. In fact, studies have shown that effects on night vision happen 3 to 5 years before we start to see signs. I would also suspect, as you can see from the research here, carotenoid levels drop even sooner before we start to actually manifest disease. Disease could take years, decades to manifest, depending on the body and the genetics in the system, but there already are these early signs. What if we started intervening in the 40s? And if you talk to someone who has macular degeneration, wet AMD, geographic atrophy, and you tell them, if you could have prevented this, or at least slowed it down, or could have maybe done something by increasing your carotenoids, would you have done it? Every single patient says, I wish my doctor would have told me about this in my 40s, my 50s, or even my 60s, as opposed to when we're typically seeing AMD in its presence. So early AMD may well develop in the 40s, as we believe, and then progresses from there. Next slide. So this brings us into what goes even beyond. I mean, obviously, for me, I have a big focus on the patients with AMD. I think it's a completely underserved population. Maybe in Kentucky, we also have a very high population because we have the second highest concentration or percentage of smokers at about 24%, which is about 1 in 4. I think West Virginia is the only higher state. Our BMI index puts us about 11th. That's not great out of 50. We're not in the top 3 there, but we are 11th. Nutrition is not high. It's amazing to see what we have in terms of health and the effects. And this applies to so many parts of the country as well. And that's where this scanner really comes in. The S3 is even going beyond AMD. And we have to realize that as optometrists, that we really should be treating the whole body, because it's all connected. If you have a healthy body and a healthy system and high carotenoids, yes, you're going to get less eye diseases, but you're also going to get less heart disease, presumably. You're going to get less cancer risks. You're going to get other diseases that should be a lower incidence. And I think we need to look beyond that. There's a great paper, of course, in one of my journals review, but this is a review of ophthalmology. And this published paper by Mark Abelson, who is out of Harvard originally and up in Boston, looked at antioxidant effects on harmful reaction oxygen species and the helpful effect against dry eye. So this is my world as well. I have a very large dry eye clinic, and I've been trying to work on those sub areas. The next area I want to look at closer is the diabetic population. But for now, I'm really focused much more on the dry eye cornea, and this is another factor for them, as well as macular degeneration. Antioxidant intake, dry eye syndrome, in this European journal study actually looked at a crossover study where they took patients, put them on oral antioxidants. They improved their steer stability, quality, and then when the crossover group, the group that got placebo, then had the chance to take the nutritional supplements, they also increased. I love crossover studies because the patients who get in the sham or the placebo are always so disappointed. But then here you are 6 months later saying, oh, good, now you get to try the treatment. And so we're going to be fair to you as well. And they're able to see the change. Believe it or not, there's actually antioxidants have been shown to enhance ocular perfusion in open-angle glaucomas. We know there are changes that occur within the trabecular meshwork that cause contraction the smooth muscle, of the anatomy of itself, and how the layers are together. And they've been able to show actually on electron microscopy for various medications how you can kind of stretch and change that. But antioxidants, as healthy as they are, as natural as they are, have also been shown to enhance ocular perfusion. And right now, there's very few medicines that can do this, and we really need to be doing this at a very early stage. And data showed that oral antioxidant supplementation, hence vitamins with carotenoids, may decrease vascular resistance over a longer period of time than previous trials investigated. So it might be even more impactful on diseases such as glaucoma as well. And then we got to get even beyond the eye. So we went from AMD to dry eye to more dry eye studies to glaucoma. And now, well, wait a minute, the way our entire, whether it's in the eye or it's in the body, and they all are supported by antioxidants, vitamin C, vitamin E, your carotenoids, as you see there, lutein, lycopene, beta-carotene, etc., that all allow the cell membranes to allow their full life, to allow them to do it the function they need to, and the components that are necessary for their lack of apoptosis in early age. And so I think it is critical for us to start looking outside of the eye as well, and because every cell is vulnerable to oxidation besides just the macula or dry eye, glaucoma, etc. And so, in fact, you could even go to looking at this as we age. You know, free radicals have been shown, and don't have to pull up studies on this because there's thousands of them, but they cause cell and DNA damage. Free radicals develop in patients who smoke, in patients who are obese, patients who don't eat fruits and vegetables, patients who have too much sun exposure and UV harm. And there are others, but those are the big four that we described earlier. Antioxidants reverse that or neutralize the free radicals to prevent or slow the aging population. So the sooner we do it, the better. And this is more than just, you know, the fact is doing the right medicine for our patients. That's the most important thing. Preventing eye diseases like macular degeneration is critical to our practices and our patients' lives. But we have a health issue too in terms of health costs. There's no denying that. You can't turn on the news without something discussing this. And healthcare expenditures, I should say, are rising out of control. They're at $4 trillion, and they represent almost a quarter of our entire gross domestic product. So people are just sicker than ever. Our nutrition is not healthy. Our cancer, heart disease, diabetes continue to rise. One of the few industrial companies that has actually had a contraction of the expected life expectancy is in the U.S. And at the same time, our incomes are declining as we're seeing more patients, and physician patients are just finding that this is not working out for us. In fact, unfortunately, I was just reading a paper that showed that the most despised industry is actually the pharmaceutical industry. And yet, I would say there's bigger issues there than the pharmaceutical industry. And if anything, the pharmaceutical industry probably gets a very small percentage in the end of what they charge for their drugs compared to PBMs and all the other middlemen that take large costs. But the fact is, a lot of this is happening because people are sick. Like, is it acceptable to see that we're having in 2011, I can't imagine the numbers today, but over 1,500 people per day died from cancer. Over almost 2,000 patients per day from heart disease. 29 plus million people have diabetes, and they say that 86 million have pre-diabetes. These are astronomical numbers. I talked about the importance of treating dry eye. It's estimated to be about 30 to 40 million. 86 million people with prediabetes. 2/3 of the population are overweight, and over 10 million people with osteoporosis, and 52 million have been shown to have bone mass loss. So it is not to put a damper on the evening, but an opportunity for us to realize that we can have a big impact on our patients' lives as well as their eyes. There are studies to show that high levels of carotenoids back for breast cancer risk reduction have been shown to prevent or to allow reduction of it. Women with higher circulating levels of carotenoids had significantly lower risk of breast cancer. And research was very compelling for this. It was led by a group at Brigham and Women's Hospital and Harvard Medical School. And they were very easily able to show a correlation to those women who had low carotenoids as having a much higher risk, higher levels of breast cancer as being positive. It also plays a role, obviously, in heart disease and all the other areas we talked about, because no one's getting optimal nutrition. USA Today has shown that in 22,000 people. What's really fascinating, though, is the sheer number of people. Almost 50% of patients do take nutritional supplements. We've got to have to guide them, though, because these supplements are not necessarily always ideal. And we can't measure their effectiveness. Some of them might be. So if you put a person on carotenoid, on a nutritional multivitamin, where they decided to go get it over the counter, like 50% of them have. How do we know if it's working? Unless they're coming into your office and they're getting scanned for carotenoids, there's no way to know these things are working and are they legitimate. New York Attorney General cease and desist notes have been sent out to a number of companies that are not manufacturing them properly or putting in ingredients that don't meet what they say on the label. There was Vitamin Shop. Talk about a name. Vitamin Shop led to contamination in one of their compounds that were utilized. And so I think doctors are going to really doctors are the ones that patients know to trust. And right now we have a major blind spot, and that's a 94% failure rate in terms of the amount of carotenoids in our body compared to the acceptable levels that they should be. And so there's a lot of factors, a lot of pointing, a lot of finger pointing and stuff like that. But the retail sales of vitamins are not the ones to point at, because their sales have actually gone up. And in fact, as I talked about, 50% of patients say that they take a multivitamin or some supplementation to date. And look at how much that's grown over that time in terms of approaching 50 billion, as they say, and in this number about 35 billion in US dollars in terms of nutrition, vitamins, nutritional supplements in the US alone. And look at the growth over 17 years. Of course, that trend has only continued, but amazing to see how steady that growth has been. Next slide. Here's part of the problem. Have you ever gone into the nutrition aisles? I talk about the artificial tear aisles as being confusing. Wow, go into the nutritional aisles. No wonder they settle on something they hear of, like Centrum or something they've heard, because they just don't do good unless there's some way to be able to, we are able to measure now to be able to tell what's happening. And so these patients really get confused. And this next is kind of comical, but look over to the left. I know that's GNC for those who kind of recognize it, but this is the manager, and this is what you want to take. Trust me. And then there have been numerous cases that we talked about of products having a label that didn't match when they were tested. There's all kinds of these groups that look at that, watchdog type event groups that look for this. And it's one of the number one things they cite as not being accurate. I mean, who are you going to trust? The optometrist that you're seeing that talks about carotenoids and the importance of them in the eye as well as in the body, or the physician, or, what we had there on the left. And as I mentioned just before I pass it over to Stephen, really there are a lot of these that can be factors. And I love what Stuart's done. Experts in nutrition. He has spent the majority of his career studying this. I've asked him what he takes, what are his supplements as well, and to understand what to take, and that's how I end up with what I am taking. He says there's actually 8 biomarkers that you should know about them that are essential. And this was published in a Review of Optometry. And the BioPhotonic Scanner is one of the 8 predictive biomarkers of future health trajectory for patients. We hope to put the scanner in all optometry schools, and many of them do have it and are in place, I'd say, already. But it's nice to see that many more are realizing the importance of this BioPhotonic Scanner, realizing its correlation to carotenoids, realizing especially the correlation to macular carotenoids and overall body health. With that, I'm going to pass it now over to Stephen, and then Trevor, who's going to take us through understanding technology a little better.
All right. Well, Paul, thanks so much for that great information. I learned some new stuff. And again, thanks for taking some time here tonight. We're going to ask you to stand by here till the end of the webinar. I know we're going to have some people that have some questions that you said that you agreed to take if we have time at the end. But what I want to do here is really just go over what this scanner score means. So we know average smokers. Paul went over this a little bit. What's nice about this is easy to implement. It's easy to discuss this with patients. It's easy for the patients to understand. In 30 seconds, done by usually in your pre-test room. Low is bad, high is good. It's kind of like a gas gauge. And if we see here, the people that take the Pharmanex Life Pack product routinely have a score on average of 100% more than the average American. And when they couple that, Paul, with what you're taking, which is the Life Pack and the youth product, we see scores up into this blue and into this platinum zone. I personally went from 31,000 thinking I was healthy, and this BioPhotonic scanner made me wake up a little bit. And now my score is routinely over 70,000, sometimes over 80. And when I was doing some juicing and wanted to beat Dr. Oz, I got up to 90,000 of this. And so what it's able to do now is when we test people and get that score, the Pharmanex supplements are the only supplements on the market, both their foundational product called Life Pack, their advanced product called Age Lock Youth, and their eye formula are the only supplements that have been proven and guaranteed to elevate carotenoid scores, or they'll actually give your patients their money back. So being able to give patients a guarantee is something they really like, and then you can show them that it's working. And so what happens is you get a baseline score. Wherever that baseline score is, you make your recommendations of diet and lifestyle. The patients take the Life Pack or other products from Pharmanex, and then you bring them back in 2 months to get another score. And again, if that score doesn't improve on the Pharmanex supplements, the Pharmanex will actually guarantee it and refund your patients. I've never had a patient that actually asked for a refund. We see close to 100% response rate within as little as 2 months. And then what that does is that validates that what they're doing is working and gives them some feedback. And then they continue to be even more compliant, continue to take their supplements routinely, continue to eat even a little bit healthier. And then we'll typically see in about 4 to 6 months, typically that's where the saturation point will be. That's where they'll plateau. And then we want to just monitor them periodically to keep their scores high. What's also nice about this is this technology gives your patients another reason to come back into the practice. And I know a lot of the doctors that are using this are selling more eyewear, they're selling more sunglasses and they're having more loyal patients because those patients are coming in the door on a more regular basis. So let's talk a little bit about why Pharmanex. And my background is I'm a chiropractor, so we do a lot of nutrition, have a lot of training on that. And it's when I was looking at different brands of supplements, it seemed like the more research I was doing on different brands, the more confused I became, because every company was telling me they're the best and nobody could really prove it. And so out of frustration, I was trying to figure out what to do. And I learned about the BioPhotonic Scanner. I started to evaluate Pharmanex and their research and development engine. And unlike a lot of supplement companies out there that are maybe started by a few physicians or a few business people or maybe a couple scientists, I was really impressed with the founders of Pharmanex. The founders are Michael Chang, who is the director of chemistry for Merck for 15 years. He developed and discovered the first statin from a natural compound called red yeast rice. Joe Chang is the other founder. He came over from Wyeth, invented a couple drugs and photocancer therapy. And Carl Gerasi, who's known as the father of the birth control pill, which I know is kind of an oxymoron, but that's what he's known for. And what their role in pharma was drug discovery. So they were experts at looking at natural products or ingredients found in nature that could be used for medicinal purposes. And during their careers in pharma, they had researched over 50,000 plant samples to identify, medicinal uses and safety that could be used to discover new drugs. And they decided that they wanted to take a pharmaceutical approach to develop natural medicine. And that was their reasoning for starting Pharmanex back in 1998 or 1995. This is their headquarters today. So the building on the top right is a $150 million building, an innovation center. 2 floors of that are a lab. They've got another $50 million facility and lab in Asia. This is the biggest research engine that exists there in the nutraceutical space by far. They house about 100 full-time scientists, of which a third of them are PhDs, collaborate with major universities all over the world, and they were the first company to get the approval to sponsor the U.S. Olympic team. So when I started to compare their research engine and quality control and labs to the other companies I was looking at, it was really hands down that this was far the superior. So these are all the different disciplines in PhDs that the company has, because not one person or 2 people have the answers. Nutrition science is very complex and it's very opinionated. So you need a lot of different experts talking together, and that's why Pharmanex employs so many scientists and so many PhDs. And what they're able to do now is go beyond antioxidants and nutrition and now actually look at gene expression. So what we know is as we get older, the way our genes function actually changes, and that's really why we age. I've got 3 young kids and they run around with unlimited energy and they heal real quick. And as we get older, things just don't seem to work as well, even though our DNA is the same. And the reason is because we now understand latest advancements in science show that you can actually measure the way the genes are functioning. I'm not going to spend much time on this right now, but you guys can always request more information on this. But essentially, you can look at young tissue and see how it functions genetically. And on the right there, that's actually what an old DNA is functioning like. So you can measure aging at a genetic level. And what Pharmanex has been able to do is leverage this science exclusively to develop a whole new class of nutritional formulas that can go beyond carotenoids and literally target the genetic sources of why we age in the first place. And they actually have a study done on their product called Age Lock Youth, which I take and Dr. Crabtree and Dr. Karpecki take. That was done at the University of Utah in humans. They looked at functional brain MRI scans, which we know the retina is just an extension of the brain, right? So it, when you look at carotenoids improving retinal function, we also know that carotenoids and some of these other nutrients are also improving brain function. And on the left side, you can see what a kind of a regular brain kind of looks like from an aging standpoint. And on the right, you can see that there's a lot more areas of activation or areas that are lit up just after 2 months of the supplementation. So this study is about to get published, but it's really exciting to be able to see the impact that we're making on brain function. We know that losing your sight as well as losing your mind are two key things that patients are interested in. And this is actually a study done on dementia and Alzheimer's looking at the role of carotenoids and omega-3s. And what they said is that people that consume these carotenoids and fish oil actually had better positive outcomes, and we're seeing those effects in the research. So let's jump into the revenue here real quick with the technology. So there's two ways of generating revenue. Obviously, you make revenue on the supplements that Pharmanex makes that are guaranteed, but now you can couple it with a testing device that also generates revenue. And these revenue streams are free from insurance. And so this is something that we don't have to worry about insurance companies kind of ruining it for us as they change reimbursement codes. The supplements are very easy to recommend for patients that have intermediate or advanced AMD. Pharmanex has an eye formula that's guaranteed to increase scores within 90 days or their money back. A lot of doctors also like to couple it with the Pharmanex fish oil, which are ultra purified and tested. And then what Paul talked about was, well, okay, that represents maybe 5% of your practice that are in that disease state, maybe 10%. Well, what about the rest of the patients? Well, those patients aren't really, it's important for them to get the AREDS2 formula. It's more important for them to take a more generalized approach to improving carotenoids and these other core nutrients. And that's where the Pharmanex Life Pack and some of the other products will come in. And those are also guaranteed and certified to improve the carotenoid status using the BioPhotonic scanner. So most physicians are charging about $20 for the test. The cost to perform the test is less than $2. So I think many physicians are seeing the impact of really scanning everybody, for the most part. Maybe there's some exceptions, but the sooner you can start. I mean, I scan my children and I motivate my kids to eat healthier because I know that if I can develop good habits for them and start to protect them at a young age, they're going to have much better habits and better health long term. So there's no age that's too young to start with this test because it's an easy test to do. And so let's say you tested 5 patients a day, that would generate $25,000 a year in cash revenue just from testing. 10 patients a day, $50,000. And if you're testing 15 patients a day, that would generate $75,000 a year just in the testing fees. And this is an income you have to wait for. Patients pay for this when they come into the office. So this device actually starts paying for itself and starts generating income the first day you start using it. On the supplements, we know most practices have several thousand patients. And if we just look at 5% of the patients converting over to this product line, 100 patients, it's about an additional $35,000 a year. 200 patients at 70,000, 300 patients at 100,000 a year. And this is in addition to the testing fees. And we have many practices that are actually doing a lot more than that. And what's nice about this is you don't have to inventory anything, deal with billing, deal with returns, deal with product support. This is all handled directly by Pharmanex. All you do is submit the orders, similar to what you do with a new pair of glasses or contacts. And rather than the patients coming to your office to pick it up, you just submit the orders to Pharmanex. Pharmanex will bill your patient's credit card and ship it directly to their home on a subscription basis. The initial investment to get started with the program is about $3,400. So not $34,000. I know most of the stuff you buy is a 5-figure plus. So $3,400 is the initial investment. You get everything you need to get started, including they give you about $2,500 worth of product that you can either resell or give to your staff as samples. We provide all the training that you need to do this. We also have a conference that you can attend as well, and then you get all your marketing material and brochures. The program is set up where you lease the device for free on a month-to-month basis, so there's no contract on it. And then the only expense to keep the device going is $125 a month. That's your service contract. It also includes your insurance. It includes a bunch of your scans and all your software and hardware updates. So you don't need to ever buy a new device or make another investment. The company will automatically update all your software as well as the hardware. And if anything goes wrong with it, you're covered under that $125 a month. And so what we're going to do here is hear from Dr. Trevor Crabtree. And like I said earlier, Trevor's been practicing for a long time. He's been doing a lot of nutrition in his practice. He's integrated it, and he's been using the BioPhotonic scanner for several years. If you guys want to contact Trevor, feel free to do so. He's got his phone number or email if he's the one that invited you onto this webinar. And Trevor, thanks for being on here tonight with us.
Thank you, Dr. Moore, very much, and thank you, Dr. Karpecki. This is something I've been in practice, as you said, for almost 30 years, and has scanned carotenoids for over 20. And initially used the flicker photometry device that has been mentioned, which was subjective. And in theory, this is a great system to use to monitor the carotenoid levels and treat. But it was flawed. You couldn't reproduce the scores or the scans. And when I walked out in a meeting and saw this technology, I said, oh, this is so much cleaner than what I'm doing now, so much better. I instantly said, I'll take 4. We had 4 offices, and I started using it, and it wasn't long before I sent the other devices back because it just fit so perfectly into the office. The staff loved it. It was easy to use. It was quick. It doesn't add time to the patient flow. And so it fit right into what we were doing. And so we continued to have the conversations of carotenoids, when it came to macular degeneration. But Dr. Karpecki mentioned a couple of times something really important that as I looked into it, the carotenoids certainly are valuable when it comes to the eye. But anyone who does any research at all, how the carotenoids are related to antioxidant levels and whatnot, there's a direct correlation to benefits with regards to cancer and diabetes and heart disease. And so I just used that as a bridge and began to have that conversation with my patients too, just more educating them than anything. And the more we talked about it, they would say, well, doc, if this is pharmaceutical grade product that's guaranteed to raise these levels, and there is a difference between the discount store items that I'm buying and what's offered here, that's what I want. How do I get that? And so we just use that as a bridge to offer that to our patients. And I practice in an area where the poverty rate's actually fairly high, and this program still does extremely well. It's been something that it has been a perfect fit for our practice. The patients like it. They appreciate it. They come back. They will give me testimonials about what they're taking and how it's worked and how it's changed them. And they like coming in. We do actually monthly rescans for free for the patient, and for them to watch their scores go up. It was mentioned earlier, how do you know if what you're taking is working? And this has validated that beyond anything else that's available. And patients appreciate that. They see their scores go up and they want to continue. It keeps them in it. And I think this has elevated our profession and has potential to do it in years to come, because I feel it makes us true healthcare providers. And as Dr. Karpecki said, we have to remember that there's not an eye sitting in the chair, it's a patient. And so we have to address all the concerns. And where we're at today as a society nutritionally, it's deplorable. So it's something that we can help, we can fix, we can have these conversations with patients, help them, and they appreciate it very much.
And Trevor, your ROI was what, less than, I know a lot of doctors want to know that. Okay, how long does it take to get an ROI? Was that less than 2 months?
Yeah, I actually, the investment, I actually had paid for the initial investment before my credit card came due, which was nice. And then the first year, it generated over 10 times what it cost me to get started. So I think the revenue is certainly a plus. I key on the patients and the benefit that we offer them. I think that's the greatest good that we're doing. But certainly with all the headwinds that we're facing in private practice optometry, whether it be insurance or discount warehouses with glasses and contacts and all the different things that we seem to be battling these days, to be able to do the right thing for the patient, to make a real difference with their health, and to have a revenue stream created that rewards you for that. This is a win-win for private practice, and I see it as something that's going to take off.
All right, awesome. Well, thanks so much, Trevor. So, where we are in the market is, this is kind of an interesting marketing chart. You have your innovators. So I was one of the innovators, getting involved with this 16 years ago. I'd say, Trevor, you were probably one of the early adopters, and one of many early adopters. And now we're starting to see, this early majority, as more and more key opinion leaders like Paul Karpecki, Stuart Richer, Jerome Sherman are endorsing this program and using the technology. We're seeing more and more trends driving towards wellness. The technology is advanced to the state where it's very easy to use. This device now has over 90 studies published. The demand for supplements continues to grow. And more physicians are looking for ways to get out of the insurance game. As insurance companies are trying to, or not trying, they are figuring out ways to pay less money. Bringing in ancillary revenue streams like this are certainly very valuable and very prudent, because the patients are spending the money anyway. Why not redirect the revenue to a better quality product? And so we'll take some time here to answer some questions, but as this survey concludes, or as this webinar concludes, when we finish up, it's going to pop up a survey. We ask that you guys fill out that survey. It'll take about a minute to do. We'll also email it out to you as well. That'll give us some great feedback to see what you thought about this. And if there is some follow-up that you'd like, we'd love to know and get back to you. We do encourage you to contact the person that invited you onto this webinar. I know we have people from all over the U.S. That are on this webinar. So again, make sure to get back to the person that invited you onto here. And then also schedule a call with us to get started. We'll also send out an email if you were invited by me or Dr. Crabtree. We'll have a link that goes out to you. But again, if you were invited by somebody else, feel free to reach out to them. And then we do have a conference coming up in October, the 17th to the 19th. It's actually the 18th and 19th, and you come out on that Thursday, the 17th, and we have a short meeting on that evening. So we find that a really great conference from science and business that a lot of doctors really enjoy doing.